Welcome to another deep dive.
Glad to be here.
Today we're really focused, turning our attention to a fascinating, complex, and frankly, critically important genus of bacteria, Mycobacterium.
Absolutely.
Our source stack for this dive is tailored specifically for you, a dental student, pulling from excerpts that lay out the fundamental biology, the serious diseases they cause, how labs grapple with finding them, the challenges of treatment, and perhaps most importantly, what this all means when you're in the clinic.
That's exactly right. The mission for this particular deep dive is to take this dense but absolutely vital information, the kind that pops up in microbiology courses, but whose relevance to your future practice might not always be immediately obvious, and unpack it. We want to distill it down to the most important nuggets, highlight those aha moments where the science connects to the clinic, and give you a solid understanding of why Mycobacterium should be on your radar.
Precisely. We're going to explore what makes these organisms so unique and, well, so challenging. We'll dive into the major diseases they cause, like tuberculosis and leprosy, which still have global impact.
Huge impact.
Then we'll tackle the often frustrating world of diagnosing these slow-growing bugs in the lab, touch on the difficult treatment regimens, and finally zoom in on why this microscopic world has direct implications for you, whether you're diagnosing oral lesions or just thinking about the water running through your dental units.
It's really about bridging that gap between the fundamental science and the practical realities of your future profession.
Okay, let's unpack this. Where do we begin with understanding Mycobacterium? What makes them?
Let's start with the absolute basics, their fundamental characteristics, what defines them and sets them apart from the vast majority of other bacteria you'll encounter. Think of it as their core identity.
Right. When you look at them under a microscope or read about their structure, what are the key descriptors?
Okay, at the most fundamental level, they're described as non-motile.
Non-motile, so they don't swim around.
Exactly. They don't possess flagella or other structures for active movement. They're just kind of there. They're also non-spore forming, which is significant when you think about sterilization because spores are incredibly resistant.
That's a good point.
And they are aerobic bacilli, meaning they need oxygen to survive, and they're rod-shaped.
Okay, so sessile rods that need air. Pretty standard bacterial shapes, maybe.
Well, yes, they are rods, but often slender, sometimes slightly curved. The source material notes they typically measure around 0.3 micrometers in width and about 3 micrometers in length. You might observe them singly, in pairs, or even small clumps when stained.
Okay.
What's particularly interesting, though, and adds a bit of visual complexity, is that some species can exhibit filamentous and even branching forms.
Branching, like fungi.
A little bit, visually, yes, deviating slightly from the simple rod morphology. It's quite distinct for bacteria.
Huh. Okay, but while shape gives us a visual, their real defining feature, their superpower, as we like to call it, is acid fastness. That's the big one, right?
Absolutely. This is the single most important characteristic when we talk about Mycobacterium, acid fastness. It means they possess this remarkable resistance to decolorization by strong acids or alcohol after they've been stained with certain dyes.
So you try to wash the stain off with acid, and it just stays.
It stays. Imagine staining most bacteria with, say, carbolfusin, then washing with acid alcohol, the stain would be removed. But Mycobacteria hold on to it tenaciously.
And this resistance is the basis for the key staining methods used to identify them, like the Zeal-Nielsen.
Exactly. The historical and still widely used method is the hot carbolfusin stain, famously known as the Zeal-Nielsen method, or ZN stain. You apply the carbolfusin dye, which penetrates the tough cell wall, especially when heated.
You have to heat it.
With the traditional ZN method, yes, heating helps the dye penetrate that waxy wall. Then you apply acid alcohol. The background decolorizes, other bacteria decolorize, but the Mycobacteria remain bright red. It's a striking visual contrast against a blue counterstain, makes them really stand out if they're present.
That bright red against blue must be unmistakable. And there are also fluorescent methods.
Yes, fluorescent dyes like auramine O and rhodamine are commonly used, often in combination, like auramine-rhodamine. These dyes bind to the same components in the cell wall responsible for acid fastness, and they fluoresce under UV light.
So they glow.
They glow. Under a fluorescent microscope, the bacilli appear as bright yellow or orange rods against a dark background. This method is often preferred in clinical labs now because it allows technicians to screen larger areas of a slide more quickly. It can potentially increase sensitivity when the bacterial load is low, easier to spot them.
Faster scanning, higher sensitivity potentially. Okay, so different visual approaches, but both relying on this fundamental acid-fast property. And the source mentions that M. tuberculosis can stain irregularly, looking beaded or barred.
Yes, that's a known characteristic. That beading or barring in M. tuberculosis staining is related to the distribution of the waxy material within the cell wall, or perhaps variations in metabolic activity. It's another subtle feature a trained eye looks for. M. bovis, another member of the TB complex, tends to stain more uniformly.
Okay, so we know what acid fastness looks like and the stains it enables. But the fundamental question is why? What is it about their structure that gives them this incredible resistance?
It all comes down to their cell wall structure. It's fundamentally different from most bacteria. Typical bacteria have peptidoglycan as a major component. Mycobacteria have that too. But their cell wall is extraordinarily complex and, most significantly, incredibly rich in lipids.
Lipids, like fats and laxes.
Exactly. Especially mycolic acids. These are very long-chain fatty acids. They're esterified to the underlying peptidoglycan arabinogalactan complex, and the source material emphasizes just how much lipid there is. Mycolic acids alone can constitute a massive 40% to 60% of the cell wall's dry weight.
40 to 60%. That's astonishing. It's less like a wall and more like they're encased in wax.
That's a very apt analogy. It really is like a waxy coat. This thick, waxy, lipid-rich layer is the key to their acid fastness. The dyes, particularly the carbylfusin with heat or those fluorescent dyes, can penetrate this layer and bind. But once bound, that lipid barrier is incredibly resistant to the action of acid alcohol decolorizers. It's like the wax seals the dye right in.
So it's not just about staining. This waxy coating must have other implications for how they interact with their environment and, importantly, with our immune system.
Absolutely. This waxy cell wall is a formidable defense mechanism. It contributes significantly to their ability to survive in harsh environments and, crucially, within the host. One major advantage it confers is resistance to being effectively killed after being engulfed by phagocytes.
Phagocytes, like macrophages.
Yeah.
The cells that are supposed to eat bacteria.
Precisely those. Our immune cells engulf them, but the bacteria can often survive inside. That waxy coat makes it harder for the phagocytes' destructive enzymes and reactive oxygen species to reach and damage the bacteria.
Wow. So they get swallowed up by immune cells, but they can survive inside. Maybe even multiply.
Exactly. They can persist and even multiply within these host cells. This is central to their ability to cause chronic infections and evade the immune response. It also makes them notoriously difficult to stain with conventional gram stain methods.
Ah, right. Even though they're technically gram-positive underneath.
Yes, based on the peptidoglycan layer. But the gram stain dyes simply can't easily penetrate that thick lipid barrier. So gram staining is generally not useful for identifying mycobacteria.
So they're wearing this tough, waxy armor that helps them survive attacks and makes them hard to detect with standard tools like the gram stain. That's quite a survival strategy.
It really is. And adding to the challenge of dealing with them, particularly in a clinical or laboratory setting, is another defining characteristic. Their notoriously slow growth rate.
Slow feels like an understatement when you look at the timelines involved in the lab work.
It truly is. While many common bacteria you encounter, like E. coli or Staph aureus, can divide every 20-30 minutes under good conditions.
Doubling every half hour or so.
Right. Mycobacteria have generation times ranging from a minimum of about 2 hours to a staggering 24 hours.
24 hours just to divide once.
For some species, yes. This means even under optimal laboratory conditions, when you inoculate a culture, it can take a very, very long time, typically 3 to 8 weeks, before you can even see visible colonies growing on a solid medium.
3 to 8 weeks. In a clinical scenario, if you suspect TB, waiting that long for a definitive diagnosis seems like an eternity.
It absolutely is. And this is a critical point for you to grasp. This inherent slow growth directly impacts the timeliness of laboratory diagnosis. If a clinician suspects a mycobacterial infection, sending a sample to the lab and waiting weeks for a culture result is standard, but it significantly delays confirmation, drug susceptibility testing, and therefore the initiation of the right specific treatment.
Which highlights why faster diagnostic methods are so important.
Precisely. It's not just a quirky microbiological detail, it has profound implications for patient care timelines and outcomes.
That connection makes perfect sense. Understanding the microbe's biology directly explains the diagnostic challenge. Okay, we've got the structure, the waxy, slow-growing, acid-fast rods. Let's move from what they are to what they do, the diseases they cause.
Right, moving from morphology and growth characteristics to the clinical consequences. The genus Mycobacterium is responsible for some of the most significant chronic infectious diseases known to humanity, alongside a group of increasingly important opportunistic infections.
And the biggest, most historically and globally impactful is tuberculosis, or TB.
Correct. Primarily caused by Mycobacterium tuberculosis. Now, it's worth noting that M. tuberculosis is actually part of a closely related group called the M. tuberculosis complex.
A complex, meaning there are others like it.
Yes, other species capable of causing similar disease in humans. This includes M. bovis, which classically causes TB in cattle but is transmissible to humans, often historically via unpasteurized milk. There's also M. africanum, found mainly in parts of Africa, and M. microti. While M. tuberculosis is the major player globally for human disease, the complex is important to be aware of.
And TB is characterized as a chronic, granulomatous, and slowly progressive infection. Let's break that down.
Well, chronic, because it can persist in the body for years, often in a latent state where the person is infected but not sick. Granulomatous refers to the distinctive immune response. The body mounts the formation of these organized structures called granulomas.
We'll come back to those.
And slowly progressive means the disease often develops gradually over time rather than having a sudden acute onset. Now, while the lungs are the primary and most common seat of infection, TB is primarily a respiratory disease transmitted via aerosol droplets. This is where it gets particularly relevant for you as a future dentist.
Uh-oh.
The source explicitly states that M. tuberculosis can disseminate widely from the lungs. It can spread hematogenously through the bloodstream to many other organs and tissues throughout the body.
And you're going to tell me that includes the oral cavity.
Absolutely. This is critical for your clinical awareness. TB is not just a lung disease. It can spread systemically and manifest in extrapulmonary sites, including the oral cavity. Recognizing these less common manifestations can be a crucial diagnostic step, maybe even the first step.
Okay, so tell me about that granulomatous response. What is this tubercle structure the body forms?
It's a fascinating battleground on a microscopic scale. The tubercle, or granuloma, is the hallmark lesion of TB. It's essentially the body's attempt to wall off the infection and contain the bacteria within a specific area. The source describes its structure. At the center, there's often a zone of caseation necrosis.
Caseation necrosis, that's the famous cheese-like dead tissue. I remember that from pathology.
Exactly. It's a form of necrosis where the tissue becomes soft, white, and crumbly, resembling cheese. It's quite characteristic. This necrotic center is surrounded by a layer of specialized immune cells, modified macrophages called epithelioid cells, which look a bit like epithelial cells.
Okay.
Multinucleated giant cells, often Langerhans giant cells, which are formed by the fusion of epithelioid cells and have their nuclei arranged in a horseshoe shape at the periphery. Then you have regular monocytes, fibroblasts trying to lay down collagen to wall it off, and lymphocytes orchestrating the whole response. It's an organized cellular fortress.
It sounds like the body is literally building a tiny containment facility around the bacteria, a biological jail cell.
Precisely. It's a manifestation of cell-mediated immunity trying to control the infection. If the host immune response is strong, the infection might be successfully contained within these granulomas, potentially leading to latent TB infection, where the bacteria are present but not causing active disease. You might just see calcified granulomas on a chest X-ray years later.
But if immunity weakens or the bacterial load is too high,
then the granuloma can break down. The containment fails. This is particularly problematic in the lungs. A significant issue in progressive pulmonary TB is cavitation. As the caseous necrosis expands and liquefies, cavities can form within the lung tissue. These cavities often contain very high numbers of viable mycobacteria, millions, even billions.
And if a cavity ruptures into an airway,
that's the key to transmission. If a cavity ruptures into a bronchus, the contents, including those masses of bacteria, can be aerosolized when the person coughs, sneezes, speaks, or even sings,
creating infectious droplets.
Exactly. Tiny airborne particles containing viable M. tuberculosis that can remain suspended in the air for hours. When another person inhales these aerosols deep into their lungs, the bacteria can reach the alveoli, initiating a new infection. This mechanism of airborne transmission is why TB is so challenging to control, particularly in crowded or poorly ventilated settings.
And tragically, TB is far from just a historical disease.
Not at all. It remains a massive global health challenge, particularly prevalent in many developing countries, but it exists everywhere. And the source specifically highlights the devastating synergy with HIV infection.
How do they interact?
HIV attacks the very immune cells, the CD4 T lymphocytes, that are crucial for controlling M. tuberculosis. So HIV weakens the body's ability to form and maintain those granulomas. This makes individuals with HIV much more susceptible to developing active TB disease if they get infected, much more likely to progress from latent to active disease, more likely to have severe or disseminated disease affecting multiple organs, and often harder to treat successfully. It's a deadly combination.
A really tragic intersection of two major infectious diseases. Okay, moving to the second major human disease caused by this genus, leprosy.
Caused by Mycobacterium leprae. This is another chronic disease, known historically for causing severe disfigurement, primarily affecting the cooler parts of the body, the skin, and peripheral nervous system.
And M. leprae has a very specific characteristic that makes it famous, or maybe infamous, in microbiology labs. Something about growing it.
Indeed. One of the classic teaching points about M. leprae is its resistance to cultivation in the lab. Historically, and still largely true today, it has not been successfully grown in pure culture using artificial laboratory media. You can't just streak it on a plate like other bacteria.
Can't grow it in vitro, so how do we study it?
It can be grown in certain animal models, like the 9-banded armadillo, which has a lower body temperature, or in the footpads of mice. But standard plates or broths just don't work.
And this relates back to Koch's postulates, right? The rules for proving a microbe causes a disease.
It does. Koch's postulates, formulated by Robert Koch, are foundational criteria. The second postulate requires that the suspected microorganism must be isolated from the diseased host and grown in pure culture. Because M. leprae cannot be cultured in vitro on artificial media, technically, this specific postulate hasn't been formally fulfilled for M. leprae based on that strict requirement.
That's a fascinating example of how real-world microbes can challenge even fundamental scientific principles. Shows science isn't always neat and tidy.
Absolutely. It forced microbiologists and physicians to rely on other evidence-consistent association, animal models, clinical presentation, microscopy, and now molecular methods to confirm M. leprae as the cause. Clinically, leprosy presents on a spectrum.
A spectrum?
Yes, broadly categorized into tuberculoid and lepromatous forms, with borderline forms in between. This spectrum reflects the different levels of the host's cell-mediated immune response to the bacteria. Tuberculoid leprosy has a strong immune response, few lesions, and few bacteria. Lepromatous leprosy at the other end has a weak immune response, resulting in widespread skin lesions, nerve damage, and crucially, a very high bacterial load in the tissues.
High numbers of bacteria in the leprinous form. That must make diagnosis easier in that case.
It does make microscopy much more effective for diagnosis in lepromatous leprosy, yes.
And given that we can't easily culture M. leprae, how do we generally diagnose it then? That pushes us towards those other methods you mentioned, like microscopy and molecular tests.
Exactly, which we'll definitely get to when we cover diagnosis in more detail. Finally, within the genus, we have the non-tuberculous Mycobacteria, often abbreviated as NTM.
Or sometimes called MOTT Mycobacteria, other than tubercle bacilli. Heard that one too?
Correct. This is a very diverse group. The source mentions several examples. M. avium, M. intracellulaire, which together form the important M. avium complex, or MAC, M. consacii, M. marinum, the swimming pool granuloma one, and M. fortutum. Many others exist too.
And unlike M. tuberculosis and M. leprae, which are primarily adapted to live in hosts, NTMs are typically found where?
They're environmental bugs. Typically saprophytes, meaning they live freely in the environment. They're commonly found in soil and significantly in water sources, natural waters like lakes and rivers, but also municipal tap water, shower heads, hot tubs, even soil.
So they're all around us.
Pretty much. This environmental presence is a key factor in understanding how they might cause infection.
Compared to M. tuberculosis, they generally have lower pathogenicity for healthy humans, right?
That's generally true. A healthy immune system can often handle exposure without developing disease. However, they are highly significant as opportunistic pathogens.
Opportunistic meaning they strike when the defenses are down.
Exactly. They cause disease primarily in individuals whose immune systems are compromised or who have underlying conditions that make them susceptible.
Like individuals with AIDS, for example. You mentioned MA earlier.
Precisely. The M. avium complex, MAC, is a major opportunistic pathogen in individuals with advanced HIV/AIDS, often causing disseminated disease affecting multiple organs. But NTM can also cause disease in individuals with other chronic lung conditions like cystic fibrosis, bronchiectasis, COPD, or even just smokers, where damaged airways provide an opportunity for NTM to colonize and cause infection. Sometimes even in seemingly healthy people, especially certain lung infections in older women.
And they cause a range of clinical problems, not just lung disease.
Yes, it varies depending on the specific NTM species and the host's immune status. The source lists localized lymphadenitis, often seen as swollen neck nodes in children who might get exposed environmentally, perhaps through soil or water. Skin and soft tissue infections can occur after trauma or exposure to contaminated water. Marinum infections in aquarium enthusiasts or fishermen are a classic example.
Right.
Pulmonary disease resembling TB is actually a major form of NPM disease, particularly MAC or M. Kansasi infections in susceptible adults. And as mentioned, disseminated disease, especially MAC, in the severely immunocompromised.
And the fact that they are common in water sources, particularly tap water, that's a very strong hint about their specific relevance to you, the dental student, isn't it?
It's definitely connecting the dots towards a common element, a potential reservoir right there in the dental clinic. We'll circle back to that.
Okay, so we've covered what these bugs are. The waxy, acid-fast, often slow-growing rods, and the major diseases they cause, from the big ones like TB and leprosy to the environmental opportunists like NTMs. Now, given their unique properties, how do we actually find them in a sample and identify them? Let's dive into laboratory diagnosis.
Right. And this is where those unique characteristics, especially the slow growth and the need for special stains, present real challenges, but also dictate the diagnostic approach. Lab diagnosis is crucial for confirming infection, identifying the specific species involved, and critically determining drug susceptibility.
Step 1, as always in micro, is specimen collection. Getting the right sample is vital, maybe even more so here.
Absolutely critical. If you don't get the right sample or handle it properly, you won't find the bug. For suspected pulmonary TB, the source emphasizes that collecting early morning sputum samples is key.
Why early morning?
Because overnight secretions tend to pool in the lower airways, and these are more likely to contain a higher concentration of organisms expelled from the lungs by coughing upon waking. This increases the chances of detection. Ideally, multiple samples, maybe 3, collected over consecutive days are recommended.
But TB isn't always in the lungs, so you might need samples from other parts of the body depending on where the infection is suspected.
Exactly. If the disease is thought to be extrapulmonary outside the lungs, samples could include pus from abscesses, exudates from draining lesions, cerebrospinal fluid, CSF, if TB meningitis is suspected.
Which is very serious.
Extremely serious. Other samples might be bronchoalveolar lavage fluid obtained during bronchoscopy, joint fluid from an infected joint, urine, stool in some cases, or biopsy material from affected tissues like lymph nodes, skin lesions, or even bone. The sample type is entirely dictated by the clinical picture, by the suspected site of disease.
And for M. leprae specifically, what samples are needed?
For M. leprae, given it primarily affects skin and peripheral nerves, specimens are typically skin scrapings or slit skin smears taken from the edges of active skin lesions and sometimes nasal smears, as the nasal mucosa can harbor bacilli. Biopsies of skin lesions or affected nerves are also important diagnostic tools. This really underscores that specimen collection has to be highly targeted to the suspected pathogen and its preferred tissues.
Okay, once you have the sample in the lab, microscopy is still a foundational tool, right? Especially exploiting that acid-fast property.
Definitely. Acid-fast staining remains the quickest way to get a presumptive diagnosis to see if any acid-fast bacilli, AFB, are present. The Thiel-Nielsen ZN stain using hot carbofuscin is the traditional method. You'd be looking for those bright red bacilli against a blue background.
Takes a bit of skill to do and read, I imagine.
It does, and the fluorescent methods are also very widely used now, maybe even more common in some labs. Yes, fluorescent microscopy with stains like auramine or auramine rhodamine is often preferred because it's generally considered more sensitive, especially when bacterial numbers are low.
Why more sensitive?
The fluorescent bacilli stand out so brightly against a dark field, they're just easier to spot. A technician can scan the slide much faster using a lower power objective with fluorescence compared to oil immersion needed for ZN stain. So you cover more ground, increasing the chance of finding scarce organisms.
Makes sense. And you mentioned specific features for M. leprae under the microscope, something about macrophages.
Yes. In smears from Lepromatous leprosy, where the bacterial load is high, M. leprae are often found packed inside macrophages. Sometimes there are so many bacilli that they give these cells a kind of foamy appearance because of all the bacterial lipids. These macrophages stuffed with bacilli are sometimes called leper cells or Virchow cells.
Wow.
And what's particularly neat about the staining, as the source notes, is the differential acid fastness between species. While both M. leprae and M. tuberculosis are acid-fast, M. leprae is actually less acid-fast than M. tuberculosis. It's more easily decolorized.
Less resistant.
Exactly. It can be decolorized by a weaker acid solution, typically 5% sulfuric acid is mentioned, whereas M. tuberculosis resists decolorization even by stronger acid, like 20% sulfuric acid. This difference can actually be used in the lab as a differential staining technique to help distinguish between them based just on their staining properties.
That's a clever trick. So even within acid-fast, there are degrees.
Mm-hmm.
And the number of bacilli seen on the smear can give you an idea of the bacterial load, right? Like a grading system.
Exactly. Labs often report the results semi-quantitatively, grading the positivity of a smear based on the average number of acid-fast bacilli observed per microscopic field. Example, scanty, 1 plus Hopley, 2 plus O3, 3 plus. A higher grade generally indicates a higher concentration of bacteria, which can correlate with the severity of the infection and, for pulmonary TB, the degree of infectiousness.
So microscopy gives you a quick look, a presumptive idea. But culture is still considered the gold standard, despite that incredibly long wait time.
It absolutely is, for several crucial reasons. First, culture allows for a definitive identification of the specific species. Microscopy can tell you A, F, B are present, but usually not which Mycobacterium it is. Second, you need a live culture to perform drug susceptibility testing, which is absolutely critical given the major problems with drug resistance, especially in TB.
Can't test susceptibility on dead bacteria.
Right. And third, culture confirms the presence of viable, actively growing organisms, which is important for confirming active infection.
And they need special food to grow, right? Not just any agar plate.
They do. Because of that waxy cell wall and their slow, fastidious metabolism, they won't grow on standard bacterial media. The classic and still widely used solid medium is Lowenstein-Jensen medium, or LJ medium.
What's an LJ medium?
It's an egg-based medium, quite rich. It contains ingredients like coagulated whole hen's eggs, potato flour, mineral salts, glycerol, and asparagine to provide the necessary nutrients. A key component, though, is malachite green dye.
Malachite green. Why add a green dye?
It's not just for color. Malachite green acts as a selective agent. Clinical specimens, especially sputum, are often heavily contaminated with other bacteria and fungi from the mouth and upper respiratory tract. These contaminants grow much faster than mycobacteria. Malachite green inhibits the growth of most of these common gram-positive bacteria and some fungi, but allows the slow-growing mycobacteria to proliferate without being completely overgrown.
So it clears the way for the slowpokes.
Exactly. It gives them a chance. Without it, the culture would likely be useless due to contamination. There are other media too, like Middlebrook agars and also liquid culture systems, which can often detect growth faster than solid media.
And then comes the test of patience.
Yeah.
Incubation. Weeks and weeks.
Indeed. Cultures are typically incubated at 37 degrees C, human body temperature, as that's optimal for most clinically relevant species like M. tuberculosis. But you have to wait. And wait. Minimum of 2 weeks, usually, but cultures are often held for 6 to 8 weeks before being reported as negative. The source specifically mentions that primary isolations, especially from samples with few bacteria or difficult specimens like CSF from tuberculous meningitis, can take the full 8 weeks, or even longer. It notes 6 weeks as a key waiting time for meningitis samples. This long incubation period is a major bottleneck in traditional diagnosis.
So while you're waiting those weeks, potentially up to 2 months, the patient might be getting sicker, or if it's TB, potentially transmitting the disease if they're not already isolated based on clinical suspicion or microscopy.
That's the reality. It underscores the pressure for faster methods. But when they do grow, the colonies themselves offer clues, right? You mentioned M. tuberculosis has a classic look. They do, particularly on LJ medium. M. tuberculosis colonies are famously described as rough, tough, and buff.
Rough, tough, and buff. Catchy. What does that mean?
Rough refers to the dry, granular, often wrinkled or cauliflower-like surface texture. Tough means the colonies are difficult to break up or emulsify in liquid. They tend to stick together due to that waxy content. And buff describes the color typically a non-pigmented, creamy, white to light tan or buff color.
Okay, rough, tough, buff. Got it. What about M. bovis?
In contrast, M. bovis colonies on LJ are typically described as dysgonic.
Dysgonic.
Meaning they show poorer or slower growth compared to M. tuberculosis. They are usually smaller, flatter, smoother, maybe more moist-looking, and typically white. So just looking at the colonies gives the microbiologist initial hints about which member of the TB complex it might be.
And what about the NTMs? How are they differentiated just by looking at the culture?
NTMs grow on LJ medium too, or other mycobacterial media. They're differentiated from the M. tuberculosis complex and from each other based on several characteristics observed in culture. Their growth rate is a key separator. They are broadly classified as rapid growers.
Like M. fortuita.
Exactly. Visible colonies usually appear in less than 7 days, or they're slow growers, taking more than 7 days, similar to TB, like the MAC organisms or M. consacii. Optimal growth temperature preference is also used. Some NTM prefer cooler temps, like 30 degrees C M. marinum. Some grow well at 37 degrees C, and some can even grow at higher temperatures, like 45 degrees C. And importantly, their pigment production is a major distinguishing feature.
Pigment. They make colors.
Some do. This is based on whether and when they produce yellow or orange carotenoid pigments. They fall into 3 main groups based on this, using the Runyon classification system historically.
Okay, what are the groups?
Photochromogens are species that develop pigment only after being exposed to light. They're pale when grown in the dark, but turn yellow or orange after light hits them. M. consacii is the classic example.
Okay, photo means light. Makes sense.
Then there are scotochromogens. These produce pigment even when grown continuously in the dark. Scoto, meaning darkness. M. scrofulaceum, or M. gordonii, a common water contaminant, are examples, producing yellow-orange pigment regardless of light exposure.
Got it. Dark growers.
And finally, the non-chromogenic species. These produce little or no pigment, remaining whitish, buff, or tan, whether grown in light or dark. The M. avium complex, MAC, falls into this group. So growth rate, optimal temperature, and pigment production in response to light are fundamental cultural characteristics used for the initial categorization of NTM isolates.
So growth rate, temperature, and color changes help narrow it down. Beyond just looking at the colonies, there are biochemical tests too, right? To get a definitive species ID.
Yes, these are performed on the cultured isolates. Once you have growth, you can do tests to nail down the species. The niacin test is a classic, important one.
Niacin, like the vitamin.
Yes, vitamin B3. Human strains of M. tuberculosis accumulate large amounts of niacin in the culture medium because they lack a specific enzyme to convert it further down a metabolic pathway. Detecting this accumulated niacin using a chemical test gives a positive result. This is a key test because it helps differentiate M. tuberculosis, usually niacin positive, from niacin negative species like M. bovis and most NTMs.
So another way to pick M. tuberculosis out from the crowd, biochemically.
Exactly. Other biochemical tests look at different enzyme activities. Nitrate reduction is another important one. M. tuberculosis reduces nitrate, while M. bovis doesn't. Catalase activity, especially heat-stable catalase at 68 degrees C, and tween 80 hydrolysis are also used in various combinations as part of a panel to further differentiate between different species of mycobacteria after they've been cultured.
Sounds like a bit of detective work, using all these different clues.
It really is, but in the past couple of decades, molecular methods have really revolutionized diagnosis, haven't they? Primarily because they are so much faster than waiting for culture.
Absolutely. Nucleic acid amplification tests, or NAATs, particularly PCR polymerase chain reaction-based methods, have become increasingly important, often essential, in modern mycobacteriology labs. These tests detect specific DNA or RNA sequences unique to mycobacteria, or even specific species like M. tuberculosis, or markers for drug resistance.
And the speed is the biggest advantage, getting results in hours instead of weeks. It's a massive advantage. You can potentially get a result identifying M. tuberculosis directly from a patient's specimen, like sputum, in a matter of hours or maybe a day or two, compared to the weeks needed for culture. This rapid turnaround allows clinicians to make critical decisions much sooner, initiating appropriate isolation precautions for TB, starting targeted treatment. It's a game changer.
And they're sensitive and specific?
Generally, yes. Modern NATs offer high sensitivity and specificity, especially for detecting M. tuberculosis in smear-positive respiratory samples. Sensitivity can be a bit lower in smear-negative samples or non-respiratory samples, but still often better than microscopy alone. And importantly, they can detect the presence of mycobacterial DNA, even from non-viable organisms, bacteria that might be dead or unable to grow in culture.
That's a key difference, detecting the bug's genetic material versus proving it's alive and growing.
It is. A positive net is usually strongly indicative of active or recent infection, as DNA doesn't hang around forever. But it's true, it doesn't definitively prove viability like culture does. However, NATs are also invaluable for rapidly detecting specific mutations known to confer resistance to key drugs, like rifampicin or isoniazid, directly from the specimen. This avoids the long wait for culture-based susceptibility testing, which can take even more weeks after the initial culture becomes positive.
Huge for managing drug-resistant TB.
Absolutely crucial. And of course, for organisms like M. leprae, where routine culture isn't feasible, molecular methods like PCR are currently the primary laboratory diagnostic tools for confirmation.
Makes sense. The course also mentions serological tests and animal inoculation, but notes they are less common now or used differently.
Right. For TB diagnosis, serological tests looking for antibodies against M. tuberculosis in the patient's blood are generally not recommended for diagnosing active disease. Why? Because the different members of the M. tuberculosis complex share many antigens. Antibody responses can be highly variable between individuals, and tests often lack sufficient sensitivity and specificity, especially in differentiating active from latent infection or past exposure. They might have some limited use in epidemiological studies, perhaps.
So not for individual diagnosis usually. What about for leprosy?
For leprosy, detecting antibodies to specific M. leprae antigens like the phenolic glycolipid I, PGLI antigen, or the LAM-B antigen mentioned in the source, can be useful, particularly in supporting the diagnosis of lepromatous leprosy, where antibody levels are typically high due to the high bacterial load. The leproming skin test, which measures cell-mediated immunity to M. leprae antigens, isn't really diagnostic, but helps classify the type of leprosy along that spectrum: strong reaction in tuberculoid, weak or negative in lepromatous.
And animal inoculation. Guinea pigs.
Historically, yes. Guinea pigs are highly susceptible to infection with M. tuberculosis and M. bovis, but generally resistant to most NTMs. So, inoculating a guinea pig with a clinical sample or culture isolate was used as a pathogenicity test, and sometimes to differentiate species. But it's slow, expensive, requires animal facilities, and has largely been replaced by faster, cheaper, more specific, and ethically preferable biochemical and molecular methods.
Okay, so a whole spectrum of diagnostic tools, from the traditional stains and slow cultures to the rapid molecular tests, each with its strengths and weaknesses, all reflecting the inherent difficulty in finding and identifying these organisms. Once found, the next hurdle is treatment.
And treatment for mycobacterial infections, especially tuberculosis, is notoriously challenging and demanding. It's a long road.
It's not just a simple week-long course of antibiotics like you might get for, say, a strep throat, is it?
Not at all. Not even close. The treatment regimens are complex, necessarily lengthy, and crucially require multiple drugs taken simultaneously. This is a fundamental principle for treating both TB and leprosy.
Why multiple drugs?
Primarily to prevent the emergence of drug resistance. Mycobacteria, like all bacteria, can spontaneously develop mutations that make them resistant to a single drug. If you only treat with one drug, any resistant mutants present will survive and multiply, leading to treatment failure. By using multiple drugs with different mechanisms of action simultaneously, you vastly decrease the probability that a bacterium will be resistant to all the drugs at once.
Makes sense. Kill it from multiple angles.
Exactly. So for drug-susceptible pulmonary TB, the standard treatment recommended globally involves a combination of 4 drugs, typically isoniazid, rifampicin, pyrazinamide, and ethambutol, for an initial intensive phase, usually lasting 2 months. This is followed by a continuation phase with fewer drugs, usually isoniazid and rifampicin, for several more months, typically another 4 months. So the total duration is at least 6 months.
6 months of taking 4 pills, then 2 pills every single day. That sounds incredibly challenging for patient adherence.
It is a major challenge worldwide. The long duration, the number of pills, potential side effects, all these factors can make it difficult for patients to complete the full course of treatment consistently. And incomplete or inconsistent treatment is a major driver of drug resistance. This is why programs often use directly observed therapy, or DOT, where a healthcare worker watches the patient swallow their medication to ensure adherence.
And that leads directly to the huge global health challenge you mentioned earlier, the rise of drug resistance in TB.
Yes, this is a massive and growing concern. Multi-drug resistant TB, or MDR TB, is defined as TB caused by bacteria resistant to at least the 2 most potent first-line anti-TB drugs, isoniazid and rifampicin.
The two backbone drugs.
Exactly. And then there's extensively drug-resistant TB, or XDR-TB, which is even worse. That's MDR-TB that is also resistant to any fluoroquinolone, like levofloxacin or moxifloxacin, which are key second-line drugs, and resistant to at least one of 3 injectable second-line drugs, like amikacin, kanamycin, or capreomycin.
It's a terrifying prospect. A form of TB that's resistant to almost all the best available treatments.
It is. These resistant strains are much, much harder to treat. The regimens are longer, often 18 to 24 months, or even longer. They involve more drugs, many of which are more toxic and have more severe side effects than the first-line drugs. They're also significantly more expensive. And even with the best available care, treatment success rates are much lower, often well below 60% for XDR-TB, compared to over 90% for drug-susceptible TB.
That's grim. And drug-resistant TB can spread just like drug-susceptible TB, right? Through the air.
Yes, which highlights the critical importance of rapid diagnosis of resistance, proper treatment completion for susceptible cases to prevent resistance from developing in the first place, and effective infection control measures in healthcare settings and communities to prevent transmission of all strains, especially resistant ones.
And what about treating NTM infections? Are they easier?
Unfortunately, no. They often have their own complexities. The source notes that many NTM species are often inherently resistant to some or even many of the standard first-line anti-tubercular drugs used for M. tuberculosis. Their natural resistance patterns vary widely between species.
So the standard TB drugs might not work well.
Often they don't, or at least not the same combinations. This intrinsic resistance, combined with the diversity of NTM species and their varying susceptibility profiles, which should ideally be tested in the lab, means that treating NTM disease requires different drug combinations. Regimens often include macrolides like azithromycin or clarithromycin, sometimes rifamycins, ethambutol, and potentially other agents depending on the species and resistance pattern. And treatment is frequently prolonged, often lasting 12 to 18 months after the patient's cultures become negative. Success rates for NTM pulmonary disease are generally lower than for drug-susceptible TB.
So whether it's TB or NTM, treatment is a complex, lengthy, and often difficult road with a constant shadow of drug resistance looming. This raises an important question for you, our listener in the dental field. How does this reality of difficult-to-treat, potentially resistant mycobacterial infections impact your role when caring for patients?
It primarily means you need to be aware and vigilant. If a patient discloses a history of TB or an NTM infection, especially if they are currently undergoing treatment, have recently completed treatment, or have a history of drug resistance, that's crucial information. It influences your infection control precautions, might necessitate delaying certain elective procedures until they are non-infectious or treatment is stable, and likely requires communication with their physician to ensure coordinated and safe care. You need to know the risks.
Okay, we've journeyed from the microscopic waxy cell wall through the major diseases like TB, leprosy, and NTMs, the lab challenges in finding them, and the significant hurdles in treatment. Now let's bring it full circle right back to you. You're a dental student? How does this detailed dive into Mycobacterium specifically relate to your training and future practice? Why have we spent all this time on it?
This is where the rubber meets the road, as they say, because microbiology isn't just an academic subject you memorize for an exam and then forget. It's absolutely fundamental to safe and effective dental practice. The source correctly states that it's a crucial component of your curriculum, particularly regarding infection control. You need this foundational knowledge.
Why? What does it allow you to do?
It allows you to understand the source of infections, how they spread, whether from patient to you to patient to patient, or even from the environment, and crucially, how to prevent that spread. You need it to help diagnose oral microbial infections, even if it's just recognizing something unusual that needs referral. And you need it to manage your patients safely and effectively, protecting both them and yourself.
And a key area of direct clinical relevance, as we hinted at earlier, is recognizing potential oral manifestations of these systemic mycobacterial diseases.
Precisely. While they might be less common than the primary disease sites like the lungs, mycobacterial infections can show up in the mouth, and recognizing them can be incredibly important, potentially life-saving.
Let's start with tuberculosis again. How might TB appear in the oral cavity? What should you look out for?
The source notes that oral TB lesions are usually secondary to pulmonary or systemic disease, meaning the bacteria have likely spread from the primary infection site, often the lungs, via sputum, blood, or lymphatics. What might you actually encounter clinically? Potential findings include chronic, non-healing ulceration, These ulcers might be irregular, indurated, meaning they feel firm or hard to the touch, and sometimes painful, though they can also be painless. They can occur anywhere: tongue, palate, gums, lips.
So an ulcer that just won't heal.
That should raise a red flag, especially if it looks unusual or the patient has risk factors. You might also see lymphadenitis, particularly enlarged, sometimes matted or draining, lymph nodes in the neck, cervical lymphadenopathy. Historically, this was sometimes called scrofula, one caused by Mycobacteria.
Okay.
Less commonly, you could encounter TB affecting the jawbone itself, causing osteomyelitis, or presenting as periapical granulomas, inflammatory lesions around the root tip of a tooth that might mimic typical dental infections but don't resolve with standard treatment.
So an unusual persistent oral ulcer or swollen neck nodes or a dental infection that's not behaving normally. It isn't just a simple local problem. It could potentially be a sign of systemic TB.
Exactly. That's the critical take-home message for you. These oral manifestations can unfortunately mimic other, much more common and less serious conditions like traumatic ulcers, aphthous ulcers, canker sores, fungal infections, or even, worryingly, oral cancer like squamous cell carcinoma.
So it needs to be on your differential diagnosis list.
It absolutely needs to be on your mental list of possibilities for unusual or persistent oral lesions, especially in a patient who might have risk factors for TB, like country of origin, medical history, immunosuppression. Recognizing these potential signs could be the first clinical clue to a systemic infection that requires urgent medical evaluation and treatment. Prompt recognition leads to appropriate referral, and importantly, also triggers the need for heightened infection control precautions in your dental clinic to prevent any potential transmission.
And leprosy also has distinct oral manifestations, you mentioned.
Yes, particularly in the lepromatous form where the bacterial load is high. The source mentions the appearance of intraoral nodules. These are typically multiple yellowish-red, firm swellings or papules that can occur on the palate, especially the hard palate, tongue, gingiva, lips, or uvula.
Nodules, like little bumps.
Yes. These nodules can subsequently break down and ulcerate, and then when they heal, they can do so with significant scarring, specifically fibromatous scars. In the broader context of leprosy, these oral and facial lesions, along with nerve damage affecting facial muscles, significantly contribute to the characteristic facial disfigurement historically associated with the disease. Again, encountering such unusual nodules or scarring patterns, especially with related facial changes, should raise suspicion and prompt appropriate referral for investigation.
So your role as a dental professional might actually include being the first person to spot potential signs of a serious systemic mycobacterial infection right there in the patient's mouth.
It absolutely could be. Your thorough visual examination of the entire oral cavity and head and neck isn't just about checking for cavities and gum disease. It's part of a comprehensive patient assessment that could uncover signs of systemic illness.
But perhaps the most widespread and critical implication for daily dental practice isn't spotting these less common oral lesions, important as that is, but rather fundamental infection control, especially regarding those environmental mycobacteria, the NTMs.
This is arguably the most direct, constant, and universal relevance of Mycobacterium knowledge for every single dental professional, every single day. Dentists and their teams absolutely must understand and rigorously manage the risk of cross-infection in the clinic. This includes patient to staff, staff to patient, patient-to-patient transmission, and also potentially infection from the clinic environment itself.
And the source highlights a very specific, well-known environmental concern within dentistry: dental unit water lines, or DUWLs.
Yes, this is a classic textbook example of environmental microbiology directly impacting clinical practice and patient safety. DUWLs are those narrow-bore plastic tubes that carry water to your instruments for irrigation, for cooling high-speed handpieces, and ultrasonic scalers.
They're everywhere in the dental unit.
Exactly, and they have characteristics that make them problematic. They often have low flow rates, long periods where the water sits stagnant, especially overnight, weekends, or even just between patients, and a very large internal surface area relative to the small volume of water. This combination creates an absolutely ideal environment for microorganisms floating in the incoming water to attach to the inner surfaces and form complex communities embedded in a protective slime matrix of biofilm.
Biofilms. those resilient communities of bacteria.
They are notoriously difficult to get rid of. And in DUWLs, the source explicitly notes that while M. tuberculosis isn't typically considered a major waterborne pathogen or associated with DUWL biofilms, non-tuberculous mycobacteria, NTM, are a significant and well-documented problem.
The environmental ones we talked about earlier.
Yeah?
Like MXC.
Exactly. Those NTMs, which we established are common in municipal tap water supplies, can enter the DUWLs when the unit is connected to the mains water. Once inside, they can readily colonize the developing biofilms, and because NTMs are relatively resistant to disinfectants, thanks in part to that waxy wall, and can survive in low nutrient conditions, they can thrive and multiply within the biofilm.
Multiply in the waterline biofilm. So the water coming out could have more NTM than the water going in.
Precisely. The biofilm acts as a reservoir and an incubator. NTMs can be amplified to concentrations significantly higher, sometimes hundreds or thousands of times higher, than those found in the original source water.
And why is this a major problem for the dental clinic? Where's the risk?
The risk comes from how that water is used. Dental procedures routinely aerosolize the water coming out of the DUWLs. When you use a high-speed handpiece, an ultrasonic scaler, or even the air-water syringe, you're creating a fine spray or aerosol cloud containing water droplets from the DUWLs.
Which everyone in the room can breathe in.
Exactly. If that water contains high concentrations of NTM shed from the biofilm, both the patient and the dental team are potentially inhaling these aerosols. The source identifies NTM as opportunistic respiratory pathogens. While widespread infection from this route is considered rare, inhalation of contaminated aerosols from DUWLs has been linked in published case reports and outbreaks to respiratory infections, particularly in susceptible individuals like immunocompromised patients or potentially even staff.
And it's not just inhalation risk.
No, there's also the risk of direct contamination. If contaminated DUWL water is used as irrigation during oral surgical procedures like extractions, implant placement, periodontal surgery, there's a risk of directly introducing potentially high numbers of NTM into the surgical wound. This could lead to localized post-operative NTM infections, which can be very difficult to diagnose and treat due to their resistance.
So those environmental NTMs, common in tap water, can basically set up shop inside your dental unit's plumbing, multiply like crazy in a biofilm, and then get sprayed directly into the air you breathe or into surgical sites. That's concerning.
It is a well-recognized potential hazard. It's a direct link between the environmental microbiology of NTM and the potential for healthcare-associated infection right there in the dental setting. This is precisely why stringent DUWL hygiene protocols are not optional extras. They are an absolutely critical mandated part of modern dental infection control for patient and staff safety.
What do those protocols involve?
They involve a multi-pronged approach. Things like flushing the water lines for a couple of minutes at the start of the day and for maybe 20-30 seconds between patients to remove stagnant water. Using chemical disinfectants specifically designed for DOWLs, circulated through the lines regularly, often overnight or weekly, depending on the product and system, or utilizing independent water reservoirs, separate bottles, instead of connecting directly to tap water, which allow the use of distilled or sterile water for procedures, or allow easier introduction of specific waterline treatment solutions. Regular testing of the water quality output is also recommended. Managing DUWL biofilms is a continuous battle, a daily defense against these specific resilient environmental organisms.
And this all falls under the broad umbrella of standard precautions, right? Which are essential for every single patient interaction.
Absolutely. Dentistry, by its very nature, involves routine exposure to potentially infectious materials like blood and saliva, and procedures that generate aerosols and splatter. Standard precautions are the minimum infection prevention practices that must be applied to all patient care, regardless of the patient's suspected or confirmed infectious status. You treat everyone as potentially infectious. It's your fundamental protective shield.
And what are the key components of standard precautions, just as a reminder?
The source reminds you that this includes comprehensive components. First, thorough patient evaluation, which includes taking a good medical history, asking about relevant conditions, including history of infectious diseases like TB or hepatitis. Second, personal protection consistent and correct use of personal protective equipment, PPE. That means appropriate masks, like N95s when high levels of aerosols are expected, especially with known respiratory risks. Gloves, changed between patients and when torn. Protective eyewear or face shields, and protective clothing. It also includes meticulous Sharps safety protocols to prevent needle stick injury.
Very important.
And third, rigorous cleaning, disinfection, and sterilization procedures for all reusable instruments and environmental surfaces. Following validated protocols for instrument processing is non-negotiable.
And specific materials, like impressions, need careful handling, too, before they leave the clinic.
Yes, that's another key point the source makes. You need to properly clean and disinfect items like dental impressions, bite registrations, and prosthetic appliances like dentures before sending them off to a dental laboratory.
Why is that so important?
Because these items have been in the patient's mouth and can be contaminated with saliva, blood, and microorganisms. If a patient happened to have oral mycobacterial lesions, for instance, those organisms could theoretically be present on the impression or denture. Disinfecting them according to manufacturer instructions before they leave your clinical area prevents the potential transmission of infectious hazards, bacterial, viral, or fungal, to the laboratory technicians who will handle them. It's about breaking the chain of infection at multiple points, protecting everyone involved in the patient's care journey.
So putting it all together, understanding Mycobacterium isn't just some obscure academic exercise for dental students. It's directly integrated into your clinical thinking and daily practice, from recognizing potential oral signs of systemic disease to understanding very specific environmental risks within your own equipment like DUWLs, and fundamentally underpinning the absolute necessity of rigorous standard infection control procedures that you will perform constantly every single day.
Exactly. Your ability to diagnose common oral microbial infections, or at least suspect serious ones and know when referral is needed, is intertwined with your understanding of systemic diseases that can manifest orally, like TB and, much less commonly, leprosy. And your fundamental professional and ethical responsibility to protect your patients, your staff, and yourself from infection directly requires knowledge of how resilient organisms like NTM can lurk in the environment and potentially spread, reinforcing exactly why protocols like meticulous DUWL maintenance and universal application of standard precautions are non-negotiable parts of safe dental practice.
Well, we've certainly covered a lot of ground. We've journeyed from the unique waxy cell wall that makes Mycobacterium so uniquely tough and resistant, through the devastating global impact of diseases like TB and leprosy, the frustratingly slow but vital process of finding these elusive bugs in the lab, the difficult landscape of treatment and the ever-present threat of drug resistance, and finally landed squarely back in the dental clinic, connecting these microscopic organisms directly to your future practice.
The key takeaway for you as you continue your training and look towards practice couldn't be clearer, I think. While you might not be the one prescribing multi-drug regimens for a patient's systemic TB treatment, understanding Mycobacterium is absolutely fundamental to your role. It arms you with the knowledge to potentially recognize those unusual oral manifestations of serious systemic diseases, prompting crucial and timely referrals. And perhaps even more profoundly, it provides the scientific rationale, the why, behind the critical importance of rigorous infection control protocols. From managing those tricky DWLs to the religious attention needed for instrument sterilization and disinfection, these aren't just rules to follow. They are scientifically grounded practices necessary to protect everyone from persistent environmental organisms like NTM, which are specifically adapted to survive in clinical environments alongside all the other pathogens you might encounter.
If we connect this to the bigger picture, the incredible resilience and adaptability of these slow-growing, waxy bacteria and their ubiquitous presence in the environment, including our engineered water systems, really drives home the point that effective infection control in dentistry isn't just about protecting against the obvious cases of infectious disease you might identify from a medical history. It's fundamentally about understanding and mitigating risks from less obvious sources, from environmental reservoirs, and from organisms that are inherently difficult to kill or remove.
And thinking about that resilience, especially NTM in water lines, this raises an important question for you to perhaps mull over as you prepare to enter practice. Given the persistent challenges posed by NTM colonization in DUWLs, the growing concern about antimicrobial resistance in general, and the constant drive for improved patient safety, how might technology, future research, or evolving guidelines continue to shape and perhaps even standardize or revolutionize infection control practices specifically related to water quality in dentistry in the coming years? Will we see entirely new approaches to water management, real-time monitoring, or maybe even point-of-use sterilization become the expected norm?
Something to definitely keep an eye on as the field evolves. That's a wrap on this deep dive into Mycobacterium. Thanks for joining us.
Always a pleasure. Great discussion.